Hi, my name is Genesis Caicedo. I am going to talk about antithrombotic therapy after acute coronary syndrome or PCI in atrial fibrillation. Okay. Definition. Acute coronary syndrome is a term used to describe a range of conditions associated with sudden reduced blood flow to the heart. Acute coronary syndrome often causes severe chest pains or discomfort. It is a medical emergency that requires prompt diagnosis and care. The goal of treatment includes improving blood flow, treating complications, and preventing future problems.
Hello, in this video, we're going to talk about acute coronary syndrome, which is a syndrome characterized by a reduction or occlusion of blood supply to the heart. And so we begin by revising the anatomy of the heart just quickly. So the heart consists of 4 chambers. The left ventricle here will pump blood to the rest of our body via the main big artery, the aorta. And coming off the aorta are 2 main arteries which supply the heart muscles itself. These are the right coronary artery and the left coronary artery. The left coronary artery further divides into 2 main arteries, the left anterior descending and the left circumflex artery. These arteries supply the heart muscles, the cardiomyocytes. Zooming into the area, we can see the artery here bringing blood and therefore bringing oxygen to the cardiomyocytes. Thus, it will result in a healthy cardiomyocyte. However, over time, atherosclerotic plaques can build up within these coronary arteries. And this is usually due to non-modifiable risk factors, such as aging, male sex, family history, and certain ethnicities such as being Caucasian. Now, the buildup of plaques can cause a reduction in blood flow to the area, to the cardiomyocytes, leading to poor oxygen supply. This can cause symptoms such as angina, chest pain, when people are exerting themselves. This is because when you exert yourself, the heart needs more oxygen and so needs more blood supply. But because the vessels can't meet the demand of the heart, you get angina as a result. Angina can be either stable or unstable. In unstable, you have chest pain even when you're resting. And this is, of course, a lot more serious. But, of course, the plaque can get worse, and it can even rupture, causing thrombosis. But the vessel is not totally occluded here, and this is what we can call a myocardial infarction still. The infarction of the myocardial tissue occurs
Application in medicine. The incidence of atrial fibrillation in acute coronary syndrome patients is ranging from 10% to 15%, 5% to 10% of patients with atrial fibrillation will undergo PCI. The cost of antithrombotic therapy in this bleeding is tricky because concern about bleeding have led to search for the best option of treatment.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy, with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 mg dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 mg dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 mg dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Pros. The antithrombotic therapy prevents atrial fibrillation in acute coronary syndrome patients or developing stroke and ischemic disorders. The evaluation of the current treatment co-heads to improve the way we treat patients and they could have the best quality of life possible. Cons. The triple therapy has more risk of brain blending than the other treatment, but with this medication, that is always a possibility.
Hello from Paris, EuroPCR 2019. My name is Davide Capodanno. I'm the editor of PCR Online, and today we discuss a hot topic. We discuss on how to manage the antithrombotic therapy in a patient with atrial fibrillation on oral anticoagulants who needs dual antiplatelet therapy. And I cannot really think of a better speaker for this topic of Dominic Angiolillo from Jacksonville, University of Florida. Welcome, Dominic.
Thanks for having me.
And I would like to keep this discussion very practical for our audience. So maybe I can take advantage of your presence and try to ask you very practical advices on how to manage this therapy. First of all, if the patient needs the anticoagulant, of course, because of AFib, which anticoagulant?
Well, there are no doubts in my mind that in the absence of contraindications, they should be on a NOAC. That is for sure. The question becomes which NOAC. On a personal note, I don't have a preference towards one agent versus another. If they already came in on an agent, I keep them on the same agent. I do not switch. If for whatever reason they're a patient on a vitamin K antagonist and do not have a contraindication, then I'll switch to a NOAC. But definitely, NOAC is the treatment of choice with full stroke prevention dose in line with the guidelines.
Oh, thank you so much. So the second logical question is how about the P2Y12 inhibitor?
Yeah, so even there, I'm pretty firm on my choice, where clopidogrel is the P2Y12 inhibitor of choice. This is very consistent with guidelines both in the United States and in Europe. We have very limited data with the newer agents, prasugrel and ticagrelor. A little bit more data with ticagrelor, particularly from one of the trials, the REDUAL trial. Those are recent analysis. I would say I would reserve the use of ticagrelor only for my patients at highest ischemic risk, but low bleeding risk. That has to be the condition, or for whatever reason, I know that the patient does not have a good response to clopidogrel.
Okay, so a NOAC first, then mostly clopidogrel with selected patients on ticagrelor. Now the maybe most difficult, at least for me, question is aspirin. For how long?
Great question. I think it's obviously the million-dollar question that we've all been dealing with. A lot of differences in terms of recommendations in the United States and in Europe. I do believe now after the Augustus trial, We do have more convincing data that a strategy of dropping aspirin as soon as possible should be considered. Now, having said that, I still believe that for some patients, a brief period of aspirin, particularly for those patients at higher ischemic risk, should be considered. But I think the overall take-home message, we should be minimizing the duration of aspirin therapy.
So thanks a lot for these practical advices. It seems that we are going in that direction, and then we have still one trial to see on edoxaban, but yeah, maybe it's time to start thinking about dual therapy and then triple therapy for selected patients. Thank you, Dominic.
Thanks for having
Thanks
me.
a lot.
Thank you.
I should operate in Ecuador. According to data collected by INET, in 2014, a total of 4,430 deaths were reported from ischemic heart disease, while from heart failure, deaths reached 103 1,316. Agreement reached 168 deaths, while those who died from cardiac arrest in that same year were 106. Conclusion: atrial fibrillation is a common arrhythmia which can lead to severe disability and mortality in the presence of acute coronary syndrome. The serious rate preceded by atrial fibrillation multiple. It is therefore crucial for physicians to know the proper way to manage this patient to guide patient decision making. Factors need to be considered including demographic, procedural, blending rights, and ischemic rights factor. The decision for triple or dual therapy, the choice and duration and antiplatelets, and the dose must take into consideration a test factor. Thank you.